Hi everyone, my name is Charlotte Morgan. I am a student at Bellevue University in the Clinical Mental Health program, and today I am going to be talking to you about having a trauma-informed response to suicidal and homicidal behavior in clients. Now, suicide is a huge mental health problem, and about 1/3 to 1/2 of people who attempt suicidality or suicidal behavior, will have interacted with someone who has mandatory reporter status and will also have indicated their risk. And as mental health professionals, how we respond to these clients can actually improve or worsen their mental health outcomes. It can also affect their willingness to engage in help-seeking behavior in the future, and it can reduce their overall distress and raise or lower their self-esteem, as well as affecting things such as their adherence to therapy in the future. Now, I have included a video that is a survivor of suicidal behavior when she was an adolescent, which you can watch at your own leisure. And she talks about how it was difficult for her to ask for help because of the stigma surrounding suicidal behavior, the shame she felt, and then the fear that she felt from other people when she did disclose that she was feeling those feelings. And that's common among people who have been surveyed in this kind of research, that the responses that they sometimes get, even from mental health professionals, feel very stigmatizing. And of course we know, of course we know that the more that we stigmatize struggles like homicidality or suicidality, the less likely people are to seek treatment. And we want to make sure that we're prioritizing the therapeutic relationship in positive regard. Now, an important note when we are talking about the topic of suicidality is that we can't paint all suicidality with the same brush. In the media, we often see acute suicidal episodes. So essentially, we see our protagonist experience a distressing event and decide that suicide is the only coping mechanism that is appropriate, and then they get help most of the time and the suicidality subsides. But of course, that's not always the case. There's also chronic suicidality, or suicidal ideation or behavior, which is a little bit different. And that can happen as a symptom of a disorder. There are several disorders in the DSM-5, like bipolar or depression, that can result in comorbid suicidal behavior. And there are also disorders that can result in homicidal behavior. And so we need to know the difference between something that is acute and something that is chronic. And we can do that through clinical interview, knowing the client's history, knowing as much information about the client as we can kind of gather during this crisis intervention process, and that can help us figure out how best to help the client. But in general, today we're going to discuss these behaviors in regards to them being a coping mechanism for clients, not necessarily a positive coping mechanism, but a coping mechanism. And we're going to talk about how we view that as clinicians and how we can use that view to help our clients. Now, our response, as I've noted, matters because, as I've said, it can predict mental health outcomes. So we really need to know how to respond in a way that is going to help our clients. We need to know the best modalities to help our clients. And we need to be aware of our own biases regarding this type of behavior because it can be very activating. Now, one method of dealing with suicidal behavior in clients is the method of hospitalization. And I think that most of us are familiar with this method. And the video I've included is Dr. David Jobes, and he is talking about how at one point this was the kind of modus operandi of the mental health field, and how as a clinician he felt like, once a client was hospitalized, they were safe. He could kind of breathe a big sigh of relief. But of course now we know that that is not the case, because we cannot guarantee that these programs are going to be trauma informed. We can't guarantee that we're not going to re-traumatize our clients. We can't guarantee that these clients will go on to seek help, or that they won't engage in suicidal behavior later, because hospitalization can actually increase the risk of suicidal behavior. And of course, there are risks and benefits to both modalities that I'm going to discuss. So one of the things that's interesting with hospitalization is, as this gentleman will discuss, it's actually, with our medical system, can place an additional burden on the client. Now, the quote that I'm currently blocking with my face is the insurance agent that was called for an adolescent client asked if he had bullets for the gun, because she was trying to assess the risk and whether the insurance would actually cover the hospitalization. And of course, whenever you're seeing populations like this that are vulnerable in general, placing a financial burden on them of a hospital stay might worsen their outcomes, along with the program not being trauma informed. So we can see a risk, an increase in the immediate risk of suicidality. And of course, the benefits of this type of treatment, as this gentleman discusses, are we may feel safer as the clinician, and in certain cases, it may actually get the client out of an unsafe situation, where they have access to weapons, where they have access to kind of the agents of suicidal behavior. So that is certainly a consideration, but we do need to be aware of the risks that hospitalization can pose. And we always need to be aware that coercion can negatively impact treatment. Now, if we do need to hospitalize clients, working collaboratively with the client instead of coercing them into treatment might help outcomes. And then we need to be aware that we are removing their rights when we do this. So while it's certainly an option, it may not be the best option. Oh, goodness. And you guys can, of course, watch the video at your own leisure. Now, I noticed in this video with this gentleman and in the research, in general, that people who had been surveyed were saying that treatments that included this type of coercion and restraint and made them feel judged were really unhelpful in reducing suicidality and homicidality. And also on the part of the clinician, avoiding the topic. So, sometimes we want to ask nicely instead of upfront. And fear and dysregulation on the part of the clinician did not help the client feel seen or heard. And of course, that makes sense. You can sense when someone is having a response to what you're saying that is not rooted in empathy and positive regard. And of course, as clinicians, I think we want the best for our clients. So we have to learn how to discuss these difficult topics in a way that doesn't make the client feel further stigmatized. And so a more helpful perspective, as James, and Gillian state, is reducing the 3 I's and the perturbance. So clients are more likely to see suicide or homicidal behavior as a coping mechanism when they see the situation as intolerable, meaning they just can't tolerate it anymore. They're kind of stuck with it, interminable. It has to change, or it has to change right now. So there is this pressure. And inescapable, meaning there are no other routes to escape. Suicide is the only way we're getting out of this situation. And the situation is so dysregulating and so intolerable that death kind of seems preferable, or homicidal behavior seems preferable. And we see that in the media, even with homicide, that you can see that for some cases, obviously not all, it was a means of escape for the person. Now, a more helpful perspective is helping the client figure out what coping mechanisms can be helpful in reducing this kind of overall dysregulation. And in reducing the 3 I's that we just talked about. So what resources do we have that are available to help the client? What coping mechanisms can we teach them? What psychoeducation can we provide them? How can we activate their support system if that's appropriate? How can we set this person up to feel like they can move past this situation? And I know in our text there was a situation where a woman had received a very stigmatizing clinical diagnosis, and she just felt like suicide or homicide was the only way out of it. And the response focused, like all crisis intervention responses, on reducing the dysregulation, moving the client to a place of safety mentally, and figuring out how we can set this client up so that suicide or homicide is not their only means of coping. And that's really important. Now, on the clinician side, we should remain compassionate, calm, and as regulated as possible. And we'll get into some reflection activities in a bit on how to kind of start to notice our own bias around these behaviors, because they can come out in very nonverbal ways, even if we're practicing ethical bracketing. Now, when we talk about care, as I noted earlier, trauma-informed care is really going to be helpful in just all aspects of dealing with suicidality and homicidality as clinicians and also as programs and hospitals. So I've noted that, being aware of the path to recovery, recognizing the symptoms of trauma, and then integrating that into kind of how we operate is going to provide better mental health outcomes for our clients across the board. Now, of course, there are a few ways that we can assess trauma preceding suicidal or homicidal behavior. My head's in the way, but that's what that says. So, of course, we have the clinical interview, where we ask open-ended questions, and we ask not in a nasty way or a cruel way, but very blunt questions. Being scared of the topic is not going to help anyone. So questions like, are you planning to harm yourself or others? And then being able to sit with the client, give them space to talk, is going to be really helpful in assessing that trauma. And clients have reported that having the room to speak about these things is helpful, and having all of the time that they need to talk about these things is also helpful. Of course, we can use the self-report questionnaires, such as the PTSD scale, the CARS assessment, the trauma systems inventory. These things are all useful. And we can also observe the client as well. We can observe their body language, observe how they're saying it, their tones, what kind of words they're using, and kind of dig into what trauma has led to this. And the most important part of this is, just like in regular clinical interview, being empathic, showing positive regard, and letting the client tell us what's going on. So when we talk about trauma modalities for suicidal patients or homicidal patients, as I stated earlier, suicidal and homicidal behaviors are generally showing up when the client doesn't feel like there's a way out of the situation, and they are so dysregulated and so perturbed and feel so hopeless that that seems like the only option to get themselves back to a state of equilibrium. So some things that can be useful for this are like brief solution focused therapy, because we're teaching the clients, emotional regulation strategies. We're teaching them coping strategies that are more helpful than suicide or homicide. Therapies like dialectical behavior therapy that work on increasing emotional regulation, because emotional dysregulation is actually a pretty strong factor in suicidal behavior. Because, we know through development that when you're emotionally dysregulated, your like cognitive processes just kind of go offline. We talk about this with crisis intervention, then bottom-up processing and top-down processing. We also need to be culturally sensitive in any therapeutic modality. And so what we're really doing is going back and teaching the client emotional regulation strategies, solutions for their problem. We're developing problem-solving strategies that don't include those maladaptive coping mechanisms. We can work on correcting the maladaptive cognitions. And we just want to make sure that we're doing so in a trauma-informed manner, keeping in mind the points that I mentioned earlier. And I have included, a cute little chart about emotional dysregulation, because this is something that I encourage both myself and you guys to do as we're moving through like checking in with your body, because it's important to also be modeling emotional regulation for the clients. Another component of this, as I stated, is knowing the symptoms and signs of abuse and neglect in children. Now, because this is, to do with children, handing them a questionnaire might not always be the best idea, because they might not be able to read it. They might not be able to understand what's going on. And obviously, like with children, they're going to be very dysregulated. So we can conduct an age-appropriate clinical interview for a child. We can make sure that they understand what we're asking. We can ask open-ended questions. We can ask about their home life. And we should know the signs and abuses of abuse and neglect, such as a child being hungry or fearing going home. The child has unexplained injuries and strange stories about how they happened. And we can kind of observe the child's behavior as well. And I think another component of this is observing the parent's behavior, or, the caregiver. How are these two interacting? And we can use, signs versus symptoms. So something like the school reporting that the child is fearful of going home might be a symptom. But we can notice, is the child bruised? Are they scraped? Do they have unexplained injuries? Do they have, inappropriate sexual behaviors? Are they hungry? Are they well-groomed? So it's going back to kind of those mental status examination questions as well, can really help us notice the signs of abuse and neglect in children. And then in Georgia, which is my state, it is not our purview to investigate abuse once we notice it. We are mandatory reporters, which means that we have an ethical obligation to report these cases to the Department of Family and Children's Services. Although I'm unsure why that says Florida and not Georgia, so excuse me. But it does work the same in Georgia. Now, there are a few local resources in my area. So for my state, we have NAMI, Georgia, and they provide training. They provide various crisis resources that can be helpful. They have a helpline. The Georgia Collaborative will actually send a crisis worker to someone. The Boys and Girls Club and the Trevor Project both have hotlines for adolescents and LGBTQIA people that can help. Now, I wanted to do an activity in cognitive empathy because I think that it's easy to look at people, even subconsciously, who are having, suicidal or homicidal behaviors and make judgment calls, even if we're not aware of them. But we can all kind of develop that empathy and break down some of our own bias by imagining that we have disclosed suicidal or homicidal behaviors, and then asking ourselves, like, what fears would we have? How would we want the clinicians to respond? What emotions are we feeling? And what would make us feel judged? And with that last question specifically, I really want everyone to think about times when they feel judged, especially by a therapist or by a parent. Was it what they said? Or were there like expressions that made you feel judged? Was it something in their body language? I think that's really useful. And then thinking about putting ourselves in the other person's shoes and what might make us feel judged. And then I've also included some reflection questions for examining bias. So one of the things that we can do with emotional regulation, it's important that we learn how to do it. So I want us all to take a minute and name what emotions we are feeling after watching this presentation. For example, I'm presenting, so I can feel some nervousness. And how does your body feel? So where does that show up in your body? So for me, I have sweaty palms because I've been talking to you. And then I think we can all take a moment and think about, what have we been taught about suicidal or homicidal behavior? So for homicidal behavior, I've been taught that people are violent. For suicidal behavior, I've been taught that that's weakness. Some of us may have religious messaging we've received. So I've also included, what does our culture or religion say about these behaviors? And then how might you have responded to suicidal or homicidal client before watching this presentation? And I know for me, I would have felt that dysregulation and that need to make the client safe immediately, and might have went for the hospitalization option because it, for me, previous to doing this research, it of course seemed safe. And I wanted to just go ahead and include some additional resources, so that we can all work on becoming more informed. So I've included the homepage for the Zero Suicide site, and they offer free online training for mental health professionals. And the Suicide Prevention Resource Center also offers this type of training. And of course, here are my resource pages. And thank you guys for listening. I hope that I have provided some insight into trauma-informed responses to these types of behavior, and I hope that you enjoyed my presentation.